Great. Well, it's nice to see so many people. So we're going to run through the safety of oil and what we see clinically as the entity that we know as silicone oil-related visual loss. These are my declarations. So how do we define this condition? What are the common features, which is really what we're going to concentrate on today? What investigations would you want to do in clinic? And we're going to touch on the underlying mechanisms. And to define it, most of the literature uses unexplained visual loss after removal of silicone oil of more than 2 lines of Snellen acuity and/or deterioration to less than 660 while the oil's in situ, and you have to have no macular cause for reduced vision at the same time. Most noticeably, we see it all clinically after oil removal because that's when the patient picks it up. And it's sudden and catastrophic when you take the oil out, or more insidious, and these are two definitely separate entities. It occurs in both macular on and off retinal detachments, and the incidence in the literature varies between 3 to 30%. The British epidemiological study that we did, we found an incidence of 2.7% for primary RDs treated with oil. And within that literature, though, there is reports of anything up to 50% visual loss upon oil removal in GRT cases. So something that we need to take pretty seriously. This is a case, so 42-year-old gentleman, macular on retinal detachment, standard surgery, was 624 while the oil was in situ, and he comes back to clinic with hand movements vision, complaining most commonly of a central black blob right in the in the centre, 2 degrees of fixation. And what do we see? Well, if you watch these patients, they develop this microcystic macular edema. It's in the inner nuclear layer of the retina. And why is it significant? Well, it's indicative of a retrograde optic neuropathy. We see it in other optic neuropathies as well. But you have to watch over time. This just doesn't appear immediately. But what we do see very quickly is thinning of the inner retinal layers. So this chap, you would look at his macula and it appears thick because of the microcystic macular edema, but if you do a segmentation analysis on your OCT, so they're thicker left macula, but then you start to look at the nerve fibre layer, he's got a thin nerve fibre layer, he's got a thin ganglion cell layer in the left eye, he's got a thin inner plexiform layer, and then when you eventually reach the inner nuclear layer, that's what's thickened and giving you the slightly higher CMT. So you need to look with the segmentation analysis at these patients quite closely. Inner retinal thinning is probably the most common finding that you'll see. You can do other tests if you have them, so microperimetry, very useful test for this condition. You see a deep central scotoma within 2 degrees of fixation. It's different to the scotomas seen from other conditions like macular off, so it's quite characteristic. And if you perform electrodiagnostics, what you'll see is a mixed macular optic neuropathy picture. They aren't specific enough to pin down the problem, or certainly the most common EDTs aren't. We keep getting asked about OCTA in this condition, so I've added a slide this year. We do see microvascular changes reported in conjunction with silicone oil use. It can affect really the inner or the superficial and deep capillary plexi. There's a loss of the vascular density. Mechanisms is really speculative. It could be that there's inner retinal susceptibility to actual mechanical damage and that the deeper changes might be ischemic. Can it play a role? We don't know. The problem with these studies is it's slightly controversial in that most are MAC off, and we know that there are microvascular changes with MAC off detachments. Underlying mechanisms, I could spend a whole hour discussing them, and we always get asked about this. Certain things are probably more important than others. We touched on impurities that you see during the process of making the compound, and there are several that you can get. Basically, polymer chains of different lengths, and it's the smaller cyclical chains that are more reactive and produce inflammation. Now, there's a variety of publications on how they penetrate the retina and can cause damage. You can get residual catalysts left over, which can be inflammatory. And these are those what they call them low-weight molecular compounds. They're small and polar. They penetrate tissue. They interact with your PFCL, and the interaction promotes the emulsification that sometimes we see. I don't think we'll go into any more on those today in the thinking of time. So this is definitely an increasingly recognizable condition. If you look for it more closely and look at the definitions of 2 lines of loss, then you'll start to find it in your macular off detachments. The OCT segmentation and microperimetry is probably your best diagnostic tool. What's the underlying cause? Well, we're uncertain. There's a whole world of research projects being pushed around at the minute, which we can discuss afterwards in the questions. But for clinicians in general, it's very important to try and understand what's in these products that you're using, because when this crops up in your clinic and the patient says, why does it happen? Well, at least you'll have some background to say, well, you know, we've investigated the products, we're not sure it is those products. My feeling, having looked into this now for 2 years, is that these patients maybe have an underlying susceptibility to the problem, hence why groups have gone out to do genetic analysis on them to try and look for oxidative stress response. But I think that's where we'll finish that one today.
Thanks very much. Anna's going to be speaking now about health-related toxicity of peripheral carbon glucose. Does anyone have any questions at this stage?